Hi, everybody. I'm Kate Folb. I'm director of Hollywood Health and Society, the group that's partnering with the Writers Guild of America East and West to bring you these weekly webinars on a variety of topics under the age of COVID-19. Hollywood Health and Society is celebrating 20 years of providing free information and access to experts to the entertainment community in a wide variety of topics, from science and medicine to health and safety and security. This is, I think, our 12th panel that we've been doing in this webinar series in this time of COVID-19. And tonight's focus is HIV in the age of COVID-19. Some of you may know, but some of you may not know, that HIV is still very much an epidemic in certain communities. And we want to encourage accurate storytelling about that topic in your shows and projects. And then now we're under the shadow of COVID-19, and we want to learn how are people with HIV dealing with that, and how maybe some of the lessons we learned with the HIV epidemic years ago can help inform what's going on today with COVID-19. And then we're going to talk about how to tell stories about these topics. So stigma, of course, is a big problem around HIV in certain demographics. So we really need more stories around HIV in general to help people to understand the realities of the disease and also dispel some of the stigma. So without further ado, I'm going to introduce our moderator for tonight, writer, producer, artist, and president of the Writers Guild East, Bo Williman. So thanks for joining us, Bo.
Had to unmute. Sorry about that. Thank you, Kate. Appreciate it. Really do appreciate Hollywood Health and Society teaming up with the WGA to help us in hosting these panels that we've been doing every Tuesday with important matters related to COVID. And of course, this week, the subject is HIV in the age of COVID. We have a wonderful group of panelists tonight, experts and storytellers, and I want to get straight to introducing them so we can be in the conversation. A couple things to keep in mind. You will have a chat window that you can scroll over on the bottom, where any resources that are mentioned, whether it's websites, books, TV shows, you name it, will be made available if they are brought up in conversation. And if you want to ask a question, you can go to the Q&A tab at the bottom, type in your question, and towards the end of the discussion, last 15 or 20 minutes, we'll go to audience questions. But you can type in your question at any time. So with no further ado, let me get to the reason why we're all here, which is these wonderful humans that are sharing their wisdom and experience with us. I'm going to start out with the storytellers. We have JANEIKA JAMES and JaSheika James. Will you wave? Say hello.
Hello.
JANEIKA began her TV career on UPN's Half and Half and went on to work at ABC Studios and later in scripted development at VH1. More recently, she's been a writer and supervising producer on Fox's Empire, co-executive producer on an untitled project for Netflix. Ooh, interesting. We might want to try to get some out of you. And an executive producer on a pilot for the USA Network, Philly Rain. Like her twin sister, JaSheika, who I'll get to in just a moment, she graduated from the University of Florida. She's received her master's degree in television, radio, and film from Newhouse School at Syracuse University. JaSheika, after graduating from the University of Florida, she began her television career on the hit series Desperate Housewives and Dexter, and later worked in post-production at ABC Studios. Her experience on a writing staff began on ABC's Revenge. More recently, she's been a writer and supervising producer on Fox's Empire as well, a co-executive producer also on an untitled project for Netflix, perhaps they're teaming up on that, and an executive producer on Philly Rain, a pilot for the USA Network. Thanks for joining us tonight. We have Jamie Rosengard. Jamie, say hello.
Hi, everyone.
Jamie has been a story editor, co-producer, and writer on the Fox series Empire, and served as a producer for the USA Network show Dare Me. More recently, she's been an executive producer and writer for a freeform show in development titled East Nasty, about the country music scene in East Nashville. Thanks for joining us, Jamie. All right, on to our experts. We have Dr. Natalie Aziz. Say hello, Natalie.
Hello.
Thank you for joining us. Dr. Aziz completed medical school and obstetrics and gynecology residence training at Stanford University School of Medicine. She obtained a joint fellowship training in maternal fetal medicine and reproductive infectious diseases at UCSF. She returned to Stanford in 2008 as faculty in the Division of Maternal Fetal Medicine and currently serves as the Director of Perinatal Infectious Diseases for her department. Most recently, she was appointed Director of Central Valley Perinatal Services for Stanford Children's Health. Her clinical and research interests include perinatal infections, HIV, HPV, CMV, syphilis, and so on, as well as maternal immunization and management of peripartum infections. Whenever I mispronounce any medical terms, please feel free to correct me. Thanks for joining us, Dr. Aziz.
Thank you. It's my honor. Thank you.
And finally, we have Dr. David Malbranche. Dr. Malbranche, say hello. Sorry, doctor.
Hey, everybody.
Dr. Malbranche is a board certified internal medicine physician and an expert in men's health, racial inequities in medicine, and LGBT health, as well as the prevention and treatment of HIV and sexually transmitted infections. He is currently an associate professor of medicine and the medical director of student and employee health services at Newhouse School of Medicine in Atlanta, Georgia. Dr. Malbranche is an experienced qualitative HIV behavioral prevention researcher who has also completed several studies on sexual health among Black men of diverse sexualities. From 2006 to 2008, he served as a member of the President's Advisory Council on HIV/AIDS. Thank you for joining us, Doctor. Okay. Let's start off with the experts so we can get a lay of the land. And we'll start off with you, Dr. Malbranche. The HIV crisis is one that began many decades ago and has gone through a lot of different stages. Can you give us, I know it's a complex and multi-decade story, but can you give us a sense of where it began, how it's evolved, where it's at now, sort of in the lead up to then on top of everything dealing with the pandemic?
Yeah, I can do that in about 3 minutes, if that's okay with everybody. He's like, great. So, I mean, we know the first documented cases were with a CDC report called the Monthly Morbidity Weekly Report back in 1981. So we're looking at almost 40 years ago. And initially when it first started off, it was obviously a disease that we saw among gay white men, and it was called gay-related immunodeficiency, or GRID, also among IV drug users. And what we've seen over time, just to kind of fast forward quickly through all the advances with getting testing and then starting medications, is we've seen the burden of the epidemic fall more disproportionately on Black and brown communities. And especially at the beginning of the epidemic, it was typically on the coast. So you saw things on New York and Los Angeles, California, San Francisco. And right now, 50% of the cases are squarely, new cases every year are squarely in the Southeast and the Deep South. So when you look at kind of what's going on with that, it's kind of had a change over time. And we can get into some of the structural reasons why that's happened probably during the conversation today. But I think, the take home is that back then, it was it was a fatal disease for a lot of people because they couldn't have access to medications. We didn't have medications. And today, as we're actually having this webinar, we have several what we call single tablet regimens, or STRs, where you get all your medications, a full HIV treatment regimen in one pill that you take once a day. And so it's very similar. So someone who's diagnosed with HIV today has a menu of different options that they can utilize. One of the other advances that's come forth is what's known as pre-exposure prophylaxis, or PrEP, where we have people that can take one pill once a day if they're HIV negative, and that will reduce their chances of contracting HIV, even with condomless sex, anywhere from 90% to close to 100%, depending on which study you're looking at. And around the corner, when we think about pre-exposure prophylaxis, or PrEP, we're also talking about injectable versions. And there was a recent study that showed that a medication that is administered every 8 weeks or every 2 months is actually just as effective, if not more effective, than the daily pill. And also we're looking at topical creams, implants, all kinds of things that you can see. So when we talk about PrEP, we used to talk of it as it was just a pill, but as the science moves along, what we're going to see is more venues or more applications where people can administer and actually choose. If you're HIV negative, you can choose your menu of options of what will be best for your sexual health and what you're most comfortable with in order to prevent HIV. And similarly, if you're living with HIV, you'll be able to live a long, healthy life by taking pills. And then they're also doing studies about injectable medications as well. So the future looks bright. We do not have a cure yet. And I want to be clear about that with everybody. And we do not have a vaccine yet. And I want to be clear about that with everybody. But the scientific advances have been substantial. The only thing is that socially, we still seem to be regressing back into the 1950s or 60s in this current day and time. So that's the big barrier that we're facing right now. The science is there, the social progress is not.
Thank you. Before I get to you, Dr. Aziz, one more question for you, Dr. Malebranche. So that takes us up to the near present, but let's rewind, less than 6 months ago, and a pandemic starts to make its way through the world. I'm curious, and I'm sure this is a complicated question, one that we're still learning a lot about, but what are some of, in big picture terms, some of the added challenges that we're facing in terms of COVID plus HIV? And I can imagine, issues of going to a hospital is a lot different now, going to your pharmacy to get medicine, social distancing. And of course, we know that COVID is disproportionately affecting marginalized communities, particularly brown and Black people, the same way that HIV disproportionately has affected marginalized communities. So I'm just wondering if you can talk to us a little bit generally about that before I get into the weeds a bit more with Dr. Aziz.
Yeah, and it's a great question. I think, what we're seeing right now with this pandemic is very comparable to what we saw when HIV first came out, and then also what we're seeing HIV doing right now, which is taking advantage of structural inequities and problems that we're seeing. And so I think with HIV, similar to COVID-19 on some levels, a lot of victim blaming happens. So individual level behavior. Well, it's because you had sex without a condom. It was because you were a sex worker, because you used IV drugs. It was because you were promiscuous. There were all these kind of tropes that were involved in it. And you see the same thing with COVID-19. It's because you're protesting the George Floyd, murder now. That's why you're getting this. Or it's because you're not wearing a mask, or it's because you didn't wash your hands properly. And so you see a lot of that blaming going on as well. So I see those parallels, but I know for a lot of the people that are living with HIV, they've had a really tough time navigating this, because when you think about a lot of the folks that are living with HIV that may not have access to transportation, or may be impoverished, or may not have insurance, and then they're having much more structural barriers with actually physically getting to care, and they may not have access to a phone and Wi-Fi to do telemedicine visits and those kind of things. So it ends up compounding what they're already going through with HIV. And if you've gotten people to a point where they're on their HIV meds, they're what we call virally suppressed, where the virus can't be detected less than 20 copies in their bloodstream, it can be really, really problematic for them to get access to care. So when we're seeing this right now with COVID-19, we're seeing a lot of stigma happening as well. And people who were living with HIV when it first started, there were rumors going around at the beginning. Oh, it's not Black and brown people that are getting it. It's just white people. Look, this is just a white people's disease. And all of us in public health were sitting there like, that's not going to be the case when we get the numbers. And as soon as we got the numbers, we realized that that wasn't the case. And then a lot of people living with HIV were sitting there thinking, well, even if I'm undetectable, which means that the virus can't be detected in my bloodstream and it's so low that I can't transmit it to a sexual partner, I probably am still at risk, higher risk for HIV than other people. And that actually hasn't borne out in the literature. And right now, like literally within the past 2 days, I've seen 2 very small studies that have shown kind of elevated death rates among people hospitalized who were living with HIV. The only caveat with accepting these as truth is, one, that they're small studies. So with a study of 9 people or 30 people, it's not going to really give you a general picture of what's going on. But then also, they fail to mention in a lot of the media reports that the people living with HIV are living a lot longer now. So close to 50% of people living with HIV are actually over the age of 50. And so they have all the other diseases, high blood pressure, diabetes, obesity, all these other things are happening. And when you look at the literature, particularly out of New York, which is the epicenter. So a lot of the data that's coming out of New York is from the early days of when the pandemic hit and kind of the onslaught that they went through. You're seeing that the top comorbid conditions that predict not only being hospitalized for COVID-19, but also dying from COVID-19 are things like high blood pressure, obesity, and diabetes. It's actually not HIV. And we don't know whether that's because the immune system is kind of dysregulated or a little bit off because of HIV, and it's constantly fighting HIV. So it can't produce that inflammation response that kind of defines what COVID-19 and how that causes damage to the lungs and all the organs of the body. But we need to do more studies. I'd like to come up here and say to you, and I'm sure Dr. Aziz will say the same thing, like, I'd like to say, oh, we know all the facts right now. But the fact of the matter is in the medical profession, we have to get used to saying we don't know because we don't know yet. And what's happening in the media is that a lot of publications are coming out with small data sets without being peer reviewed. And it's taken as full science and as, you know, manna from heaven, where people are like, this is fact. And we have to actually pump the brakes and say, you know what, we don't know. We need to get more information first. So I'll punt that over to Dr. Aziz as well, because I know she has a lot to say on the topic as well, but those are my thoughts on that.
Thank you, Doctor. Well, Dr. Aziz, I mean, of course, you're welcome to comment or expand on anything that Dr. Malbranche just discussed, but I also would like you to tell our audience about your clinic and what it's like on the ground there. You know, the work that you generally do, how it's been affected by the pandemic. And I think one interesting thing to note is, you know, a lot of people, I think there's stereotypes about HIV being more urban, and you're in a rural environment, a rural clinic. So you might be able to educate us on how things are the same or different there.
Absolutely. Thank you so much again for having us. And Dr. Malbranche, I want to thank you for setting such a beautiful stage and uplifting stage when it comes to advances in medicine for HIV therapy and treatment. That being said, I wanted to just segue from what you were talking about in the 80s and 90s. As we know, HIV was predominantly diagnosed in younger men, for example. However, now the backdrop is completely different. Our pregnant patients make up a large portion of HIV positive individuals in the United States, and these are heterosexual women that acquire HIV not through IV drug use, not through blood transfusions, not through high-risk behaviors, but heterosexual intercourse, which may be with their single monogamous partner, for example. So the face of HIV has really changed over the past 30 to 40 years. On a very, very uplifting note, I just want to say that we often don't get such great successes in medicine. You know, we can try all we can to prevent preterm birth, but our initiatives make some difference, but we don't see the dramatic decrease that we've seen with perinatal transmission. I have to say it's one of the most inspiring things in my career, in that you can help a mom who cares dearly about her baby who is infected with HIV actually reduce those chances of transmission to the baby to less than 1%. It requires a wonderful teamwork where the mom takes her medications and we, you know, have her maintain her viral load, as Dr. Malbranche discussed about viral load suppression, whether it's below the level of detection or below a certain set. It's with mom coming to routine prenatal cares and her prenatal care visits, as well as making sure that baby gets that 4 to 6 week antiretroviral prophylaxis. In industrialized nations, it's usually the decision to not breastfeed, so that because breast milk can also carry HIV, it's a way to reduce transmission. And then finally, mode of delivery aspects. But believe it or not, even now, where we really want to make sure that we do everything we can to help reduce transmission, most moms do not require cesarean deliveries anymore, which was a completely different thing 20 to 30 years ago, where a lot of moms had to have C-sections because their viral load was greater than 1,000. And now I have to say it's with pride that our vaginal delivery rates are so high for HIV positive moms. And I just want to say that we can normalize HIV like diabetes or hypertension. It just takes a wonderful partnership amongst the providers as well as the patients. So with that, we have taken HIV perinatal transmission with these efforts from the CDC and physicians and obstetricians to less than 1% perinatal transmission. That is a significant decrease of over 95% from the early 90s. You can imagine what a wonderful victory that is. I hope one day we can get to 0%. Basically, it's never, you know, I'm being greedy here, but I do think that it's possible. And just even from the 2000s, from 2012 to 2016, based on the CDC's data, we have decreased perinatal transmission by 41%. So that is tremendous. So those are the things that inspire us and make this success story so invigorating to tell again and again. And I think it's still important because, again, it takes that proactive action between the patient and their healthcare services. With respect to what I do in the Central Valley, so I'm actually from the Central Valley originally. At 18, I said goodbye to my parents and went to UC Davis, and I was gone for 25 years, where I spent most of my life at Stanford. I thought I was going to die at Stanford, but there was an opportunity where Stanford was looking to extend their university high-level care, perinatal care for mothers and babies into the Central Valley. It is one of the places that's most underserved. For example, in Stanislaus County, we have one of the highest syphilis rates for pregnant women and for babies in the whole nation. In fact, just last week, I had a baby that unfortunately has acquired syphilis, and we were able to save the baby because we sent the mom to the hospital and we noted that the baby was in distress and needed to be delivered. So those things are, you know, they're right under our noses, and the Modesto Central Valley area is just an hour and a half from San Francisco, from UC Davis, from UCSF, from Stanford. And yet it's a world apart in terms of healthcare services and underserved patients that really need our, you know, our contributions to the community. And it's really an honor to come back and serve my community. I was, you know, just a small town girl from a local public high school, and to give back to the community is really inspiring. But it's to basically bring that level of care. We even bring, for example, pediatric cardiologists to my clinic in Modesto so that patients don't have to go to the Bay Area when they have lack of transportation. And when babies need to be delivered at Stanford, for example, I had a patient in the Central Valley that had HIV, and the hospital was not comfortable delivering because they just haven't had many moms that have required this care and this expertise, or the doctors that have the expertise, such as infectious disease doctors and neonatologists and pediatric infectious disease doctors and high-risk MFM doctors. We actually can take moms and house them in the Bay Area at Stanford for the several weeks before they deliver, so that there's no fear on the part of not making it to where their baby needs to be to get the best care possible. So with that, I think I have the greatest job on earth, and at the same time, I have one of the most, you know, heartfelt jobs, and sometimes it can be heavy on the heart, but it's definitely a privilege and an honor to serve my community here.
Thank you. That's really inspiring, Dr. Aziz. You know, I know as a storyteller myself, my brain is, the gears are already turning, like, oh man, it would be amazing to tell a story about a mother who's HIV positive, going through that process of pregnancy with her partner and everything, you know, and the dramatic moment of the baby being born, and is the baby negative or positive, you know? But we're here to talk to some other storytellers who've actually been down the path of telling complex and layered stories about HIV, maybe not in that particular setting, but in one that's equally as important and that hasn't been told very much. So I want to go to JANEIKA and JaSheika first, and just, you know, give us, you know, I'm sure there's many Empire fans that are watching, but there might be a few people that have not seen the show and or not caught up yet, and not familiar with the storyline in which you all tackled, a romance between two characters who had to confront one of the partners being HIV positive, and particularly PrEP, which is something that not a lot of people know about, but a lot more people know about it now because of your show. So can you give us a little bit, and Jamie, I promise we'll bring you into the mix, but we've already got two people in one frame. So if we had three going on at the same time, it might be a little tough. So let's start with JANEIKA and JaSheika.
This story was probably one that was a long time coming on our show. Empire was a show that took on a lot of issues, head on, from its, inception, essentially. And it almost seems like this was something that was inevitable for us to address, given how we address so many, issues of, justice and, racial inequities and things like that. But it was one that took a long time, to kind of come about, because of, the preciousness around the story and how we wanted to tell it. And it was actually Jussie Smollett who really, really, really pushed for this, story that involved his character, Jamal, a very beloved character on our show. And wanting to, really kind of address, the HIV, epidemic itself and in the community, not just, the LGBTQ plus community, but also, in particular, the African-American community. Our show is about an African-American family. The audience is heavily African-American, and it's a disease that is, as we said earlier, there's disparities between like who it affects. It affects African-American, people more. And in addition, African-American females, more right now, looking at the statistics. So it was something that we really wanted to address. And there were a lot of discussions around it. We were just kind of grateful to be able to bring it to pass, finally in the 5th season. And set it up through Jamal and this love story. It was kind of like a three-parter where he's in this relationship with this journalist named Kai, and we go back to the past in the previous episode, outside of our episode, where we see how they first met, and even the nervousness around the Kai character of he's dating this guy and he's kind of getting close to him, and then finally he has to confess, like, hey, just to let you know I'm HIV positive, and how we wanted our character to respond to that, and even other characters on our series, how they were going to react and respond to it. Exactly. And our episode in particular took the opportunity to kind of inform, enlighten, and educate the audience, because it was when another one of our beloved characters, Cookie, played by Taraji Henson, she became aware that, her favorite son, we don't like to say it out loud, but Jamal was her favorite son. Right. Is dating a character that is HIV positive. And it was something, and just to like go back a little bit, just in terms of, the discussions around us telling this story, we had a debate, if I'm being honest, in the room around, if it was going to be a story that involved Jamal, because there's the idea that, is it stereotypical to tell this story with our gay character? Do we put it, do we tell this story, around somebody else, another, cast member? And there was a lot of dialogue around that, but we wanted to make sure that we told the story in a way that was going to be the most impactful, and not necessarily periphery. We put it, right, in the audience's face with, our beloved character, but also with somebody that we were introducing into our world who also became a part of the family. So it wasn't just, like a one and done, like it was something that was ingrained within the season and told, and then, continuously addressed, to the point that, Jamal ends up marrying Kai, who's HIV positive. And that was also important for us to literally show, an HIV positive character who's thriving in life. It's not a death sentence. It was important for us to not tell a story of, a character just kind of being down and dragged down and, inevitably dying because of this virus. We wanted to make sure, like, we talked about before, normalizing this, because, it is becoming normalized, you know what I'm saying? And just to be able to, show that, not only can you live, but you can also love, you know? So yeah.
And have babies.
That's right. That's right.
Jamie, well, give us a sense of your perspective and of this process of developing the story. And I mean, it's so wonderful that we have three talented storytellers here that can give us real insight into, like, I'm sure a lot of our viewers would really love to get in the weeds, those moments where the room maybe like was at a fork in the road, like, oh, there's this big decision we have to make. Do we go left or do we go right? Or do we toss that aspect of the story altogether, or how much do we lean in? Can you give us some specific examples of kind of behind the scenes and some of those moments, and also how you guys conducted your research?
Yes, so everything at Empire is always a lively discussion. We do not have any shrinking violets on staff, which I think helped us really find the best way to tell this story. And it was definitely contentious, something that we struggled with a lot, and I'm fully willing to admit that I was one of them, is just worrying that with Jamal, that we tended to tell a lot of stories through the prism of his sexuality. And it was something we really worried about, that we were telling everything about his experience as a gay man instead of letting him have the same type of storylines that his other two brothers on the show did. But thankfully, one of the beauties of our writers' room from the inception, because of Lee Daniels and Danny Strong, is that we have an incredibly diverse staff in every possible way, including a writer on staff who is HIV positive and who really impressed upon us the importance of just showing this as something as normal and not something that needed to be a massive dramatic storyline in every episode, but could just be something that Jamal's character took completely in stride. So that was a huge breakthrough for us in the room, just hearing about somebody's direct experience with it. And then some of the debates, as JaNEIKA alluded to, were about who exactly we wanted to be diagnosed. One person that we explored was the character of Maya, who was introduced in a previous season as the daughter of a woman that Cookie was in prison with. And we thought that might be an interesting take on it, to do a young heterosexual woman who it just happened in the course of her finding herself through her sexuality. But ultimately, we thought that making it Jamal's partner in Kai was the most powerful choice because of the way that it would bring in Cookie. And Cookie is our, by far the most beloved character on the show. She really, we used to joke in the writer's room that she was like the Fonz, because she was never allowed to do anything wrong. Everyone just loved her too much. And this was the rare instance where we were really allowed to challenge her point of view on something, because she was not excited when she found out that her son was dating someone who is HIV positive. And we didn't want to demonize her reaction. We tried to root it in something real, which is that when she was in prison with other women who were dealing with this, that it did seem like more of a death sentence, and there was much less education about it available to her. So we tried to root that in reality. And we brought in her two sisters, played by Tasha Smith and Vivica Fox, to help talk her through it. But ultimately, I think that seeing her come around and seeing her realize that this was something that she could just take in stride, and that didn't have the connotations that it did back when she first heard about it, was incredibly powerful for our audience.
Yeah. And just to speak about some of the research that we did, a lot of the work that Jussie Smollett did outside of Empire had to do with the Black AIDS Institute, which he was a part of, and working with Artists for New South Africa, which dealt a lot with HIV prevention and eradication in U.S. and South Africa. So he connected us with Phil Wilson of the Black AIDS Institute so that we could get a lot of information, the statistics, and just a lot of the perspective, and some of the conflicts that people come up, when you're not aware necessarily, about the virus, about the disease, and particularly when it comes to PrEP, which was something that I never heard of PrEP until I watched that episode of How to Get Away with Murder. So just
which is the only other show, to our knowledge, that has tackled this. So yeah, I'm curious. Yeah, tell us tell us at what stage in the process did PrEP become part of a story? And also, we got a little bit of it from Dr. Malbranche, but just to repeat for our audience what PrEP is, I'm curious, like when did that enter the narrative in the writer's room? Did you know from the beginning? Did that come sort of mid-stage? And it would be great if you could talk about that. And then I also know that, Kate told me that you had a great story about
Yes,
in Botswana and how this connected with them, which of course in Africa, HIV crisis is profound. So anyway, so I turn it back over to you. You got a lot of ground to cover. Go for it.
Yes, well, thankfully we had Phil talk to us about, PrEP, and as Jamie said, one of our writers is HIV positive, so there was a lot of awareness, around the drug and how it's used now. It's particularly, helpful in ensuring that HIV is, not a death sentence and not, we can be engaged with lovers who are positive, and in a safe way, and it not be a problem.
And it also coincided with, I think, a lot of the first commercials for PrEP. So it was also interesting because it played into the pop culture narrative. I think some of those early commercials were a little bit ambiguous about what exactly PrEP did, but there was obviously a huge appetite for learning more about it. So there was a fun way for Jamal's character just to be able to refer to it and make it just something that's normal and that people could really look up and find easy access to.
Exactly. And one of the purposes of us doing this story is so that we could inform and educate, audiences across the world. And you don't realize how much of an impact, we're in the room, so we're in the bubble, so we don't realize necessarily how much of an impact some of these storylines are having, across international waters. And we were informed by one of the writers in our room that, he got a call from one of his friends who was working in the Peace Corps in Botswana, who shared with him that there was a sudden influx in requests for PrEP. And when she asked, they don't advertise it out there. So when she was asking, patients how did they hear about this? They told them that they heard about it from watching Empire. So it just kind of speaks to the impact and the importance of, having these stories play out, in visual mediums, so that we can get this information out, to the community and to the world beyond,
Yeah, I wanted to mention, someone said earlier that there were a lot of discussions in the Empire writers' room about, whether you wanted to make it stereotypical or whether it would come off as stereotypical if the Black gay character was centralized in the story. I want to be very clear with the epidemiology here that 2/3 of the new HIV cases are among men who have sex with men. 2/3. When we talk about Black women contracting HIV, they make up 80% of the remaining 20% that are among heterosexuals and IV drug users. So still, from a sheer numbers perspective, it's the burden is still, we're not going to say it's a gay disease because it's not a gay disease, but the epi is real. And so we have to deal with the facts here. And among that group of men who have sex with men, Black and Latino MSM are making up the majority of the cases, far outweighing what their representative in the general population is. So it's one of those things where, like, if you feel like you're being stereotypical, when you go to the numbers, then you can kind of say, well, okay, this is kind of what's going on. And I think, some of the stories that can be told are not only from the perspective of, it's kind of like a heteronormative HIV negative, trying to explain it away to that population.
Right.
And I think one of the things that you can do is also give people really a bird's eye view, because it's not just PrEP. We also talk about what's called treatment as prevention. So if we do undetectable as untransmittable, and I know Phil talked to everybody about this, with that part of it, but that in all of the studies, you look at like 81,000 condomless sex acts between couples where one partner is positive, one partner is negative, whether it be heterosexual or same gender loving couples, 0 transmissions if the partner who is HIV positive, if their viral load is undetectable. And so that science is absolutely ridiculous, and I think is a part of it. And I just want to put this in because I know we're going to talk about stories, but I want to put a plug in because what I've seen in the media a lot, and I think what's great about the story that was on Empire, the story on How to Get Away with Murder was great because it introduced people to these dynamics. unfortunately, we fall into these stereotypes. We're like, oh, the Black community is so homophobic. Oh, the Black community hates HIV. And oh my God, the Black community hates gays. And there's no intersection between, it's either the LGBTQ community or it's the Black community. And I'm like, yeah, so it's not an either or scenario. The two are not mutually exclusive. And so, it's also like, you don't want these stereotypes of that Black people have a monopoly on homophobia or sexual prejudice, because that sure as hell ain't the case in this day and time that we're knowing. And so someone like Jamal's character can experience sexual prejudice or homophobia and also get called the N-word at the same time. And that can happen because people tend to forget that Black gay men are also Black men on top of that. Exactly. I think what needs to happen at this point, this goes back to something that Dr. Aziz said earlier. She mentioned patient-provider relationship twice, and I want to just pound that home because, again, I'll bring it back to what I said earlier, is that we have the science. We have treatment as prevention, we have PrEP, we also have post-exposure prophylaxis. And if y'all need some stories about horror stories with post-exposure prophylaxis, I can give them to you. But what I don't see a lot that's represented in the media that is happening every day, it's not the stigma from our communities. It's not the stigma, the HIV stigma from the Black community, or from the Latino community, from the white community, Asian communities. It's stigma within medical communities. People that have guidelines that are working on the front lines, whether they be nurses, front desk, phlebotomists, physician assistants, nurse practitioners, or physicians themselves, that carry their own religious, racial, sexual orientation, gender, all these biases with them. And they don't neatly just throw them out the door when they walk into the clinic. That once they put on that white coat, that doesn't mean that all their biases that they go in every day just automatically gets engulfed by the white coat and they're fine. These people will turn somebody away or say to a heterosexual woman, oh, you're not at risk for HIV, you're married, you don't need PrEP. They'll do some crap like that. Or if it's a Black gay man who comes in and says, I need PrEP, or I just had unprotected sex or condomless sex last night, and, I'm worried about HIV. Can I get post-exposure prophylaxis, which is when you have to get it right after you have an event to prevent HIV. And a clinician will say to them, you know what? It wasn't really a high risk. You don't need it. The patient is actually physically there. He knows his sexual health. He knows what he wants. He knows his level of risk. And the provider turns them away. And that's not based on a guideline. That's not based on facts. It's based on their own personal bias. And when you draw the parallel, when you look at like law enforcement and how what happens a lot of times, someone kills Rashad Brooks in Atlanta. And what do they say about? Well, he shouldn't have fought back. Well, he was drunk. Well, he was sleeping in his car. Yeah, all that stuff is true. But the problem was that the cops went overboard. The same thing happens in the medical profession. Well, you shouldn't have slept with somebody without a condom. Well, you shouldn't have been on drugs. Well, you shouldn't have been using poppers. Well, you shouldn't have done meth. Yeah, all that judgment and individual level blaming of the person that's coming in for help is not helpful. And we need to look at the system. So some of the stories that need to be told are not about the communities that are stigmatizing us or the people that are wanting to take their sexual health into their own hands, but it's actually the medical communities that we go to when we're vulnerable and we want to be helped and we're at our lowest and we need help. The medical community sometimes fails us. And those are the stories that we need to see, because particularly when we're talking about Black and brown people, and we talk about structural inequalities and structural racism within law enforcement and in politics and within the prison industrial complex, it happens within the medical communities as well. Medical communities are not immune to racism, sexism, gender identity prejudice against our trans brothers and sisters, none of that. They carry the same prejudices that general society does. The problem is they have the science to prevent HIV, and sometimes their biases get in the way.
Thank you,
May I just
Please.
add a little bit to that too? I always think we just shouldn't be health advocates as physicians. We need to be health partners. We need to be community members. And when I think it's so important that you need to go a step beyond, and I completely agree with your statement. There are so many patients that come to me who do not use PrEP, who do not, and I ask, has your doctor, and this is a couple that's coming once they're already pregnant, so you know that they are sexually active. And I've asked so many people, has your physician ever offered you this? No, doctor. And we know that as physicians, we are the strongest supporters, but also the strongest advocates for patients to then take our recommendations. For example, women who are offered and recommended vaccinations will take them more than if a doctor doesn't mention anything to them and doesn't say, I support this. I think this is important. So what you say, Dr. Malebranche, is so important. And I think that it needs to be taken into account. You know, we all have these biases, and what we can do is try to break them down and try to look within ourselves and see what we're doing and how we're contributing to this. But I really feel that so many partners who come to my clinic have never even been offered this amazing therapy that can prevent HIV transmission.
So we've got some questions rolling in from the audience. They're mostly directed towards our experts, but I want to stick in storytelling just for a minute more. Dr. Aziz, I mean, we've heard from Dr. Malebranche about systemic phobias and biases in the medical industry. That is not a story that's being told enough or properly. You mentioned earlier, you know, stories about how partners that are having children are contending with with the mother being HIV positive. I don't believe I've seen that. What do you have any other things that you feel in the realm of HIV are stories that either have not been addressed at all or have been addressed incorrectly?
Well, I think that I think, you know, I think there's always opportunity to increase education and knowledge and acceptance and brother and sisterhood, basically. So I definitely think we can address these more. One of the things that I was most impressed with just this past year, I take care of a lot of patients who acquire HIV during their adulthood. Well, I took care of a patient this time who had acquired HIV through her mother, through perinatal transmission over about 30 years ago. So, and this was, you know, it's a less common case than the typical pregnant patient that may come in that has acquired it through heterosexual interactions, basically. The important thing that I realized was that my patient felt stigmatized by me, because when I addressed her, I said, oh, I have all these protocols and I can check your blood every month, which is even more than what's recommended, but I just like to be really and she felt that I was thinking that because she's HIV positive, that I considered her non-compliant, that I considered her maybe more high risk than my other patients, for example. So it was a great awakening in that you never know what somebody or how somebody may feel about their general setting. And no matter how much I think I connect with my patients, there's always a way to learn more and to be humbled by them. And that was one of the things that at her postpartum visit and at her last pregnancy visit was something that I thanked her for, was to opening my eyes more and seeing that how a patient who's lived with this all her life, who's felt identified and targeted and had a scarlet letter of HIV from beginning, from when she was a baby, must feel when people are like, oh, I'm going to take, you know, I'm going to do everything I can. She felt like I was just taking it overboard, basically, which I have to say, it was the best learning lesson for me. And that patient continued her care with me, even though she thought maybe I didn't understand her initially, because you try and you say, I'm sorry. And you say, I want to be a better doctor. Can you help me be a better doctor? So I think those are really important things. And along similar lines, I feel that the stigma of feeling like you have an infection, you have something that people are scared of, is seen in COVID as well. For example, some of my patients who come to labor and delivery, where we are routinely testing all pregnant women who come in for delivery. And you know, pregnancy is a stage of your life where you're always in the hospital, you're always in clinics, you have to be hospitalized. So it's healthcare is right there with you. And sometimes too much, because unfortunately, we are seeing the same things happening, health disparities, social determinants of health affecting our communities with COVID as well. At Stanford, only about a third of our patients are of Hispanic population, and about 40% are state insured, yet Hispanic and state insured patients make up almost 90% of our COVID positive patients who are pregnant, who we identify, whether it's through asymptomatic testing or symptomatic testing when they come through the ER or clinics, or when they're coming in to get delivered, and we just test everybody. So I think it goes to show you, not everybody can quarantine. People have to work. People have to have a roommate to have a room so that they can stay and afford housing. And I think it's very important to keep those things in mind. And we've had actually several refusals of COVID testing, because I feel that some patients are now feeling stigmatized, and they're saying, well, you just think I have COVID because I live with my family, or I have to work for a living and can't do video conferencing. I have a physical job that I need to take care of. So I think it's very important to think about that stigmatization and how patients feel, and how we can take things from our lessons in HIV and really try to normalize normal health processes in patients' lives. So I think it's very important to take those lessons and to apply them to what's going on now, because COVID is being seen as that scary disease, that scary infection. Patients will come in, and if they see us wearing PPE, which is preventative protective equipment, personal preventative equipment, they say, oh, does that person have COVID? Do you have COVID in the hospital? It's very frightening for people. And that's normal.
I think it's a really interesting point, which is that stigmatization about COVID can help remind some of us of the early days of HIV, where there was a lot of controversy, there was a lot unknown. The medical community was figuring out as they go along, and drawing those parallels. We are flying to this hour, so I'm sorry to cut you off, Dr. Aziz, but I want to make sure that we get to some of the audience questions, and this is the speed round, so we're going to have to try to keep our answers brief so that we can get to all of those. Before we do, I have just one more question for our storytellers. I know in the shows that I've worked on, there's really tough choices sometimes where you just say, I don't have enough room. You know, I've only got so many pages. Jamie, can you tell us, was there anything that you guys had to cut out of the story, or something you wish you could have tackled but you just didn't have space for?
One component which Dr. Aziz alluded to is that in our case, both Jamal and Kai are men of means and have a lot of financial advantages, and also are very educated and were familiar with and aware of PrEP and HIV medication and undetectable and untransmissible and all of those terms. And I think that we wish that we could have found a way to explore that with characters without some of those advantages, and we tried to speak to that in our final season through a trans character, Melody, who just pointed out that even though Jamal faced more struggles than he should have had to, that it was always coming from a place of wealth. So that was something that I think we wished we could have made more explicit.
JANEIKA, JaSheika, if you were to tackle, a HIV story or a character or a constellation of characters in any of your future projects, and maybe you intend to, but you can't tell us yet, are there any things in particular that you would, just as a storyteller, that's something that we'd really like to explore?
I think what Dr. Aziz said about pregnant women who have HIV and being concerned with transmitting it to their newborns, like that is completely something that I've never even thought about, so that's a story that I wouldn't mind tackling. Absolutely. Yeah. And you just spoke to something. We are telling a story in which that is a part of the storyline. It's a story in the 70s and 80s. So kind of when it was just coming about. Yeah. In the film. You're talking about the pilot in the film project. On the film project. Oh yes. Oh yes. But that's for another day. But yes, we are actually going to be exploring. We're going to be interesting.
Yeah. I don't think Deadline's watching per se.
Right. Yeah, it's a long way down the line. Yeah.
Excellent. Well, let's get to our audience questions. We're going to go a little bit over time, obviously. We encourage thorough answers, but do please keep in mind that we got a few questions to get through. And a reminder to the audience, if you have a question, now's the time to ask it, because we're reaching the end here. So from Julian, from a community perspective, what are some actions medical practitioners, health educators, public leaders, places of worship, and celebrities can take to advocate for people in need of care and help reduce the stigma surrounding HIV/AIDS during COVID-19 in African-American communities or other communities of color? Now, that's a lot of subgroups there, but Dr. Malebranche, perhaps you can tackle a few in short order.
Yeah, I mean, I think everyone has to use their voice. And I think Dr. Aziz had said earlier about being an advocate for your patients. I believe in that. I also believe in being an activist for my patients. So I will tell stories. I will write narratives. I will use social media to promote things or call out health inequities when we have patients or people that can't vocalize that themselves or don't have the power, or even if they don't feel they have the power to be able to reach the upper level people in order to make changes made on a systemic level. I think a lot of us who are working in these professions can use our voices to do that. So whether you're a writer for a television show and you can tell the story like that brings it to the attention of people, or if you're a provider or an administrator that's working in a clinic that can do that, there are ways we can do that. And you'll see a lot of medical professionals, we are storytellers. And so we will actually tweet stories. We will actually publish narratives in the Journal of the Medical Association, the American College of Physicians, New England Journal of Medicine. We all have these things where we get folks out there, and there are websites that do the same thing. So I think there are ways we can do this, particularly using social media.
Wonderful, thank you.
Can I just also add very quickly that I would say engage those communities that you're trying to give power and voice to. I think bringing them within the project that's being worked on is the most important part of this. It's to engage the community, include the community in the project, not just do something, from an ivory tower, for example, but really to bring in representatives of the community and let them tell you what they need and let them tell you how they need to be supported.
And don't start with an idea and then ask for their approval of it. Actually have them brainstorm at the beginning. That's what a real partnership is about. It's not about, oh, we had this idea to do this. Are y'all okay with that? And then, if they're not, and then if they're not, you're like, well, we kind of want to do this anyway because we're going to do it. But bring them in so they actually are the originators of the ideas.
Wonderful, thank you. Dr. Aziz, can you please comment on home HIV self-testing options now during COVID-19, social distancing for women or their partners concerned about their HIV status?
Well, I think that HIV is such an important status to know. I also think it's an important status to be appropriately counseled about. So I do think that these kits are helpful in terms of for those patients that may not be able to go to a doctor or may not be able to, visit a physician. However, there's other ways to really have your physician partner with you to be able to get this done. Now with COVID, so many of our visits are being done either through telehealth or even by phone, for example. So if a person does not want to go to a clinic, they can always discuss these things with their physician or their medical clinical provider, because I think this is a very important aspect. For example, if I were to build a house, I would need a contractor's guidance to help me. And I think this is emotionally and physically very challenging to try to understand. So I think it's a very important aspect of status, and I think everybody should know their status, everybody, but I do think that it needs to be done with appropriate medical professionals who can actually guide and counsel and do post-test counseling as well. So I think that's very important. Dr. Malebranche, I think you probably have even more input on this and more expertise than I can offer.
Yeah, no, I think that's right on the money. And I also saw a question just about telehealth and PrEP. And what I think is happening now is that people can go in for an initial visit and be seen, get all their labs drawn. And these times where they would be told to come in a month later or 3 months later, they actually can do a virtual visit as kind of a check-in, because we're finding out that you probably don't need to check for some of these labs until every 6 months or so. So that's okay if you can do that. So I think telehealth is kind of changing things. There are also ways in which pharmacists are actually leading PrEP. Nurses are leading PrEP. It doesn't have to necessarily be a physician assistant, or a nurse practitioner. It can be a lot of different people along the continuum working as a team.
Great, thank you. And one more question now. This one is pretty specific, so it may require, Dr. Malbranche, a little bit of explanation to the lay people here. Writers are perhaps more familiar about PrEP than non-occupational. I think PEP, I think you have the question in front of you. I don't know if that's a typo or not. Can you please explain the process of NPEP for HIV risk post-exposure and the application to a storyline? Is this a relevant clinical option now and during COVID-19? I feel like I just read a question in ancient Greek.
No, I think you were good. That's fine. So if you break it down really simply, PrEP is for pre-exposure prophylaxis, which means you take it when you're HIV negative. You take a pill. Right now, it's only a pill that you can take every day that prevents HIV. When you talk about post-exposure prophylaxis, that's called PEP. And when they say non-occupational, that means sexual or some other way outside of if you're in occupation, like in you're drawing blood and you stick yourself with a needle. That's what it means when it's non-occupational. So post-exposure prophylaxis is different in that it's kind of event-driven. And so instead of being HIV negative and taking a pill every day, and then if you have a condomless sex encounter, you're like, oh, you know what? I'm good because I'm on my PrEP already, so I should be covered. Post-exposure prophylaxis is when you're not on anything, you have a condomless sex act or something happens and you're like, oh shit, I need to do something now. And people will actually draw the parallels with birth control and stuff like that. Like people will go in to get, it's kind of after the event happens. So the rule is within 72 hours, you are supposed to go in and you have to start on a 3-medication full HIV regimen and take it for a month, and then you're done. And what a lot of people do is that, and you can go into an emergency room, a clinic, your primary care's office, as long as you get within 72 hours, you start the medications within 72 hours, that's when it's going to be most effective and be able to prevent HIV the best. But people sometimes have problems doing that, so it can be an issue. And I also would want to say with post-exposure prophylaxis or PEP, people can finish that month. So you get your blood drawn, you basically take a full HIV regimen as if you were living with HIV for a month, and then you come in a month later for your follow-up labs and counseling and other sort. And what a lot of people do at that point is they say, you know what, I may have condomless sex in the future, I'm just gonna switch to PrEP. So somebody can go from just using post-exposure prophylaxis every time it happens and just kind of almost like an event-driven, like, oh shit, this happened, let me go ahead and take these medications now to prevent HIV, to, you know what, I just want to have this pill on board. A lot of my patients would call it their gay vitamin. A lot of my gay patients would say, I feel like I'm on birth control. That's what I feel it's like. And so they would actually tell these stories to me that that's what it felt like to them. And so I think, you know, people can do post-exposure prophylaxis to prevent that one event that they had. And then after that, speak with their provider and say, you know what, I want to have this pill that I take every day so I don't have to rush and start to take a full HIV treatment medication afterwards. So it depends. I mean, again, I stressed this earlier, but the point is that people have options, and there are options out, and you can do all these things together. You can do them with condoms, without condoms, whatever your choices be, whatever you're most comfortable with. I think that's one of the most important parts of all this.
Thank you. I feel like I kind of understand right now. So good job. You got it through my control. Look, we're close to being done here. I'm going to turn it over to Kate in a moment, but this is the part of the evening where I like to give everyone an opportunity to mention any resources they think might be helpful to our audience, whatever they may be, whether it's a website, a book, if they want more in-depth sort of education about all of these issues and beyond. So, you know, I'm going to go one through one here. And if you can't think of one right away, go, oh, shoot, like yeah, I just thought of one, then just, we'll come back to you. But let's just try to do a quick rundown here. And for our storytellers, if you want to plug something that's upcoming or that you're currently working on, or there's another show, and doesn't even necessarily have to be about HIV per se. This is a time where a bunch of smart people with a lot of curiosity get to say, hey, check this out. So let's start. Let's put Jamie on the spot first.
Well, we've mentioned most of the resources that we used on Empire, but I will say that the piece of artwork that's been sitting with me most profoundly over the last 2 months would be Todd Haynes' Safe. And so if anyone has not seen that film, I think it's a perfect moment to speak to both of these issues.
Wonderful, great. JANEIKA and JaSheika, you have to give us at least 2, since there's 2 of you.
Yeah, just to reiterate, the Black AIDS Institute was extremely resourceful for us, and currently right now, just with everything that's going on in Black America, particularly as it pertains to HIV, COVID-19, as well as, racial injustice, and just the trauma of all 3 at once, you can go to blackaids.org for that. 2. I'm like, I just said Black AIDS Institute, Black AIDS. Yeah, okay.
You could also just tell us your favorite thing you're watching or reading
That's
right
all,
now.
Folks. Favorite thing I'm watching right now, or something that I just enjoyed recently, a Netflix show, Never Have I Ever.
Okay, great. Fantastic. Yeah, sometimes we need a break from all the heavy stuff,
Yes.
Wonderful, thank you. Dr. Aziz.
Well, I'm part of a group of individuals who work on the Priority COVID Pregnancy Registry. It's a wonderful registry that's based out of UCSF and UCLA, and I am just one of the mere people that just call in, basically. But there are amazing leaders who are utilizing this time to really have a registry that can look at obstetric outcomes for COVID, and also it's partnered with the Birth Inequity Program at UCSF so that we can really try to learn about COVID and how it affects our communities in different ways. So I think it's a really important project and registry to basically to sing about.
So is there
yes, it's called it's just priority.com. So I can put it in the chat. It's just priority.com. And again, it's based out of UCSF and UCLA, and the 2 principal investigators are OBGYNs from UCLA and UCSF.
Terrific, thank you. Dr. Malbranche.
The CDC.gov website is good both for HIV and for COVID, and for the intersection of HIV and COVID-19. Thebody.com and thebodypro.com gives a lot of great information. That's traditionally an HIV website, but it has been pulled into doing a lot of COVID. Poz.com, POZ.com gives a lot of great information, again, intersectional with COVID-19 and HIV. And then with regards to just HIV in general, I was part of a series with the Greater Than AIDS campaign in the Kaiser Family Foundation called Ask the HIV Doc, where I worked with Dr. Dimitri Daskalakis, and we put together these little 1.5-minute shorts that were questions asked by young gay and bisexual men just about PrEP, sexual health, living with HIV, HIV treatment. And still to this day, we taped a lot of those 3 or 4 years ago. I still get people commenting about them and how much they enjoyed them and how helpful they were. Wonderful. So you could just Google Ask the HIV Doc and it'll come up.
Terrific. It's our wonderful folks at Hollywood Health and Society are making these things magically appear as you say them in the chat room. So as you can see, the sun is getting low in the Midwest. I'm losing my light. So I'm going to punt it over to the West Coast where they have a little more sunlight. Before I do turn it over to Kate, I want to thank our panelists so much. I've learned a ton. I'm sure the same goes for everyone that's been viewing. Thank you so much for your expertise, your passion, your knowledge, and sharing a little bit of time with us during these extraordinary and trying times.
Kate.
Thank you for having us.
Hi, okay, I think I'm here. Can you all see me?
Yes.
Hi, everybody. Thanks so much. Thanks, Bo, for your fabulous moderating, and thanks to all of our panelists. This was a really great discussion. I know it could have gone on for another hour easily. But thank you all for joining us. For the viewers, before you go, at the end of this panel, a survey will pop up, and we would love your feedback on what you think about this panel and our other events. If you can't answer it then, you'll probably get it in an email tomorrow anyway. We would love your feedback regardless. Thanks again, everyone. This was a fabulously stimulating conversation. Best of luck to everyone. Stay safe, stay healthy, and have a good evening. Good night.
Bye, everybody.
Bye, thank you.